Good afternoon or good morning, depending on when you're listening to this. So this is our 4th episode of the Respect podcast, going out to the whole ICS and hopefully introducing some interesting concepts around respect and correcting some myths that might be held. So as usual, I've got a group of really knowledgeable people with me today, and I'm going to ask them to introduce themselves. So first of all, Caroline.
Hello, so I'm Caroline Toman. I'm an advanced clinical practitioner, paramedic for South Western Ambulance Service.
Thank you for coming today. Fiona.
Hello, I'm Fiona Eggerton. I'm a community frailty matron based in the North Cotswolds.
Nice to have you. Sonia.
Hello, I'm Sonia Vaz Fernandes. I'm a geriatrician who has the great luxury of working part-time in the frailty unit, but also in Cheltenham community locality.
Lovely to have you. And Jean.
I'm Jean Fisher. My background is nursing and I work with the Palliative Care team across Gloucestershire, and my role is communication skills.
And for those of you that haven't listened before, my name is Dr. Tanya de Weymarn. I am an emergency medicine and frailty consultant and clinical lead for end of life for the ICB. But in general, I'm just a respect enthusiast. So our particular focus today is going to be on the clinical recommendations box on the respect form. So that bottom box that some people think is most important and I think is less important, but we'll let other people talk about their views. So I think it always makes sense to sort of think about maybe the patient journey in an emergency as a starter for 10. So Caroline, what do you want to say about the clinical recommendations box? What's useful, what's not useful?
I've personally found that it's all quite confusing. Even for me as an advanced practitioner, I still find it confusing. If you think about our newly qualified paramedics that are having to make those decisions, like early hours of the morning, how they actually interpret those words is quite difficult and can end up or lead up to the patient being admitted to hospital unnecessarily. So particularly reversible causes is my favourite one.
Yes.
And the ward-based care is also another one. What does that actually mean is what we need to discuss further.
So others will have heard me talk already about those phrases that I hate. Admission for reversible causes and ward-based ceiling of care, but I'm going to let other voices explain why they're so bad at the moment. So tell us why they're such bad phrases.
Ward-based ceiling of care, I suppose, obviously working in the community doesn't really mean anything to me. I suppose it's saying if the patient is in hospital that they don't go into the intensive care unit. I presume that's what it means. So I don't have anything. It's really not relevant to me in the community.
So I think for me, if I am thinking about that box 4, or in fact the plan in general, the whole point is that it is about purpose, or this lovely Japanese phrase, ikigai, right? So your ikigai is your purpose in life. And the whole point when we are making these plans is to try and help people live their life with purpose, on purpose, until the last moment of that life. And so what you write in that box, their purpose in life has to be the compass, right? Which guides whatever you put in that form. How do you know what to put in the bottom part? You need to look at the top part, which says about what is it that matters most to me? I think that the actual phrase is what do I value and what do I fear? So if you can have that bit filled in, then it becomes so much easier to write your clinical recommendations. I mean, if we take an example, I said I work in the community and also in the hospital. So I have something to do with care homes and patients there. So we might be having an MDT and discussing somebody. And for example, what if they have stroke risk factors, right? They might be telling me that this person is quite functionally disabled, high frailty score, requiring a lot of care and support, etc. But what matters most to them is the granddaughter that comes every single week and they love to talk to her and it's just so precious, but they can't move, they're hoisted, etc. So what if they had a stroke that affected that speech? That's the thing that's giving them ikigai, purpose in life. So in your recommendations, when you're saying, okay, they have risk factors for stroke, etc., What shall we do if the care home person comes and thinks, oh, she can't speak today? Should we call 999 or not? How do you decide what to write in there? Well, you might want to say, the thing that she values most, her life won't be worth living, is if she cannot speak to her grandchild. Therefore, I am not a stroke specialist. I think it is appropriate to send you to hospital to be assessed, to see whether there is any hospital-specific emergency treatment that you can have, which will preserve that speech. However, if you get to hospital and find that actually, do you know what, we think that this is a ginormous stroke and you're likely to not survive this episode. And on her fears section, she might have said, you know what, I do not want to die in hospital. I want to be at home during my last breath. Then we perhaps need to put a little proviso. Of course, it would have to be, there's a lot of ifs, ands or buts in all these conversations. So with the care home staff, I would be saying, okay, yes, you might be saying that if it's going to be her final illness, we want her to be at home, but we want to save her speech. So therefore, in this MD2, we might say, go for an assessment, but come back to the care home if we think this is a final illness. But you as a care home then have to be saying, we would be willing to accept you back out of hours. As a team, we know we talk about working in an ICS way. The hospital then needs to be clear that they're going to communicate clearly and provide relevant information, drug changes, whatever we need. So those are the kind of details, And sometimes it's okay to write things like death and dying in that bottom section so it's clear.
We actively encourage the words death and dying, really important words to not be scared of using. I think what you're saying is really true, that whatever we write in that clinical recommendations box, there's always going to be ifs and buts. And even if you write an entire book, you're never going to cover the exact situation that SWAST are being presented to. Thankfully, we do now live in a world where we can phone a friend, although sometimes getting hold of the correct friend is a bit tricky. But I think all of the people that are reading this are going to have some level of professionalism and in their own practice, within their own competencies, are always going to be able to think about the clinical course within there. But if they don't know, as you say, these values and fears, then they can't do anything. And I often say that if I've got values and fears and a clinical summary written and nothing in the clinical recommendations boxes, I can make something up. I can, as a normally competent, definitely confident clinician, I can make a plan. Whereas if you've only written something in the clinical recommendations box, I'm never going to be able to work out these values and fears and summary from that. I just wanted to go back to the ward-based ceiling of care. It's not just the community it's not helpful for. It's actually not helpful for the emergency department either, because, as you say, all wards are wards, including intensive care is a ward. I hate the phrase ceiling of care because we never stop caring. We might have a ceiling of treatment, but we don't stop caring. And as you hinted at, most people actually mean that this patient wouldn't be a good candidate for intensive care and for intensive organ support. And if that is the case, then write that. We're in such a complicated position anyway. If there is something that is really clear, write not for ITU. It's got fewer letters than the ward-based ceiling of care and is actually more helpful. And I think the other thing is that having any phrase that is a stock phrase, we just need to really consider it, because the whole point of Respect is about personalised care. And if we're just writing a thoughtless phrase, which is what I feel ward-based ceiling of care or admission for reversible causes is, then we're really not providing personalised care in any way, shape or form. Anybody else want to say anything about that? Sorry, my hobby horse. I will climb off my hobby horse.
I think it's very difficult as well for anybody that's worked just in the community or anybody that's just worked in the ambulance service to actually knows what goes on in the hospital. So, that's in terminology, like ward-based care is completely alien to us because we don't know what goes on in the hospital and we don't know at what point of somebody's treatment they would be going off to sort of high dependency and things like that. So actually, if we talk about the classic one for us is a sepsis, and particularly with the patients that really are end stage terminal. Sepsis is a reversible cause, isn't it? But how do we determine that at that stage they're going to go into hospital, they're going to die anyway, and that isn't what we want for these patients. So I think it's having that better understanding of what this terminology means, if that is how it's going to be. But it's very difficult, isn't it, to create a sentence that is going to fit every area of healthcare, isn't it, for all to understand? But then maybe the education needs to be better right at the beginning of somebody's training, isn't it?
Yeah. Just to be really clear that the majority of people actually die of an infection in the end, even if it's their cancer or their dementia or their frailty or their renal failure or whatever. And even in sudden things like trauma, it's quite often an infection that gets them at the end.
And that's where the reversible causes thing can become even more complex, can't it? Because writing something like patient is comfortable to have antibiotics, but not intravenously, or would accept intervention A, but really does not want to go back to hospital. I hope that would help the ambulance service if it's them that gets there first.
Yeah.
Absolutely. And obviously, as pathways are developing as well, we do have hospital at home. So, really, if you did need IV antibiotics, is that something that we could provide in the home? I think the main point is, do they want to go to hospital or not, isn't it? That is the main thing.
Can I just say one other thing? Because it is right at the front of my head right today. Sometimes we might write, patient would like to die at home. Great. Mm-hmm. I think it's really helpful to have, if that's not achievable, would like to be admitted to the hospice. Hospice is very often the patient's second choice of care place. And that does give the family a bit of a get out of jail free card from that guilt that they will feel if they can't hack it in the last.
Yeah,
I agree.
I think that's a really important thing to say about any respect plan. It's not a legal document. It's not set in stone. So people may well want to die at home, but it is perfectly appropriate for there to be a change of plan. And unfortunately, with all of our clinical recommendations, we should aim to make it past the 3 a.m. test. And really sadly, we can't always get access to a hospice at 3 a.m. So again, we wouldn't necessarily be able to follow that at sometimes we can delay and say, well, that's what we're going to aim for at 10 o'clock tomorrow morning. But what I hate to see is when people are brought to hospital and somebody says, but this says they weren't to come to hospital. And then there just ends up being a fight, which is totally inappropriate. So I have to say, as another phrase I don't like is ones where it says not for admission to the acute trust. And because saying wishes to die or would like to die at home when the time comes, that can still be what they'd like, but it still leaves lots of options open. And if we can add more information about other options, that's definitely a good thing. Sonia, I want to bring you in to talk about polygamy and good relationships. Yes, she knows where I'm going with this.
I always laugh about this because I'm a Christian and I shouldn't be promoting things like this. But the key is that in the respect process, it is a polygamous thing. Now, it's not necessarily going to be one person who just goes, right, we must sit down today and finish this thing. Sometimes it's about, planting a seed, and it's for all of us to think, where is our opportunity here? So I might be a renal consultant, seeing somebody in the clinic, seeing their GFR tail off slowly and thinking to myself, yes, this person would definitely not be a candidate for dialysis. But who have I told? How will it impact? You're saying you're going to see somebody in the community with their sepsis and their GFR down in their boots. And we want to know, is this person going to be a candidate for dialysis or not? I always have this thing in my head about they need to gain more than they're going to risk if they're going to attend hospital. Anybody can come to hospital, right? There's a very negative perception, I would say, that respect is relating to denying people things. You can't come to hospital, you can't have IT, you can't have CPR. But actually, it's about trying to get you more of what you want and less of what you don't want at a really important time in your life. And we're generally dealing with frail older people. So each one of us who interacts with the person, we should be asking ourselves, is there something relevant here? I might be the carer in the care home who is doing some personal care, and this person just says to me, oh, I'm quite fed up. And perhaps they've got that link and they realise the fed up is not fed up of being washed, but fed up of this current life and existence. And does that care home, or in our case, do we have a forum where the HCA can be at handover and say, oh, you know what, this is what was mentioned to me today. What is on our advanced care planning? I came across somebody just this last bank holiday weekend who had been in for, I think, 4 or 6 weeks, having every antibiotic under the sun. And I was asked to come and see him. And if I'm honest, I thought he was dying. Not imminently this second, but in the very near future. And when we had a heart-to-heart conversation, he had come to that conclusion. I talked about being in the last chapter of life, and all these courses of antibiotics had tried to add extra pages, but now actually we were heading towards the last page, and I thought that maybe another course of antibiotics is not going to help you, even though there seems to be some shadows on your x-ray, etc., etc. And sadly, I had to have a conversation on the phone with his daughter. But again, this polygamous relationship, already the ward sister had been involved, the usual consultants and teams had all been involved, telling them various bits of information. But we again had a very open conversation, and her first thing was, I want to have Dad home to die, essentially. But we weren't afraid to use the word die. And so I think each of us just has to have the courage to have the little bit of conversation that we have. We don't have to know everything. We should only do the bits that we are competent in. So I wouldn't expect that HCA to be filling in the clinical recommendations. But if we have the opportunity to have our polygamous relationship where everybody can have a foot in, an arm in, let's not go down that route. If they can have their say, it will give us such a rich picture. And that's that bit when you were talking in the beginning, Tanya, about we want to know what matters most and what I fear, and the picture at the top. It's not just the list of all the diagnoses. It's, this is Susan. She has always walked everywhere and rambled, and she loves her dog, and she loves to do X, Y, Z. Whatever that is, that's the picture that I want. Versus this is somebody who is hoisted doubly incontinent and all care, as I heard about in an MDT this morning. But they might be that one who loves to talk to their granddaughter. So that's the bit that we need, the richness in the picture.
And it's about listening to that.
Yeah.
Because my husband, who is totally non-medical, was an inpatient not that long ago. And he was really upset, actually, on a fundamental level, that the patient opposite him kept saying, I just want to go home. I can't live like this. Very, very elderly man. I would rather be dead than be in hospital. And he said it to all levels of staff, including the ward round, the nurses that came. And for my husband, who was sitting there just as a layperson watching this, he couldn't believe that the person wasn't listened to. Yeah. And this was not just a throwaway comment. It was a very sustained belief. And he did need some assistance to maybe make his family understand that was where he was at, but the health professionals and the staff were listening to the family much more than the patient themselves.
I find that a lot. I hear that a lot.
Yeah.
I agree with you. It has to be very person-centred. I'm so pleased you said that, because I wrote that on somebody's respect form yesterday. This man likes to go for long walks. He likes to tell jokes. And, a hospital admission is really not what he wants, but he's happy. If he falls over and breaks a bone,
exactly,
he would have to go, So, but you want the personal details, you mean.
Yeah.
What is that person.
What's the meaning
that being,
for them?
Yeah.
And in that example that you've given, he's a rambler. He likes to go for walks. So if he breaks a bone, he's potentially going to be off his legs. He needs that fix because that is taking him back to his purpose. As I said, it's that, what is that matters most? I want to be able to walk and do things for myself. So therefore, when we make any decisions in that clinical box, it's got to be, is this decision going to take this person towards their purpose or away from their purpose? If it's taking them away, then why are we writing it down there? If it's taking them towards, brilliant, that's what we should be doing. Well, I feel quite passionate about that.
Going back to the
I think we all do here. That's the great thing about. I just love sitting and having these chats with people because it's my tribe. So
going back to the going home, to die if they're on that pathway, if they are, it is going to be their end of their life. From a practical point of view, it isn't always possible.
Yes.
Because if they live on their own, you do need someone there 24 hours. It's very difficult. It can be arranged a lot of the time. And I also work for a palliative care charity who do night sits and things like that. So yes, we can do that.
But it takes planning.
But that's... Yes, it takes planning
and resources.
And resources
that might not be there and available at that point.
But if you don't talk about it in advance, you have no chance of getting it. If you talk, and this is, again, it comes back to that being honest. We need to say, look, yes, I know you want to die in a hospice. I had this conversation just the other day. Yes, you do want to, but actually, and this daughter was very realistic. She said, yes, I know there might not be a bed, but at least if we know about it, then when the 999 person rocks up and goes, what to do? Oh, hospice. Okay, let's see if that's an option. And I suppose part of it is about what expectations are we creating? We want to hear what you want to say, and then we have to check it and say, is this a realistic expectation? And balance it out. And also coming back to what you were saying about relatives, same with this man here. He was very clear that he thought he was in his final chapter for a few weeks, and he was doing what he was doing or agreeing to the treatment because of his daughter. So when we're listening to the different voices, trying to bring them together so that we can have a sensible and, as you say, personalised plan on that section at the bottom.
Jean, you looked like you had a big think then, or something that wanted to pop out.
I guess it was to do with patients agreeing, because patients particularly, I think, a certain generation of people will agree if they think that's what we want them to do, or we're saying, you really need to go to hospital, we really need to sort X or Y or Z out. And it's so easy for us as clinicians to do that because that's our place of comfort. But it might well not be the right thing for that person.
Absolutely. And I think the easiest way to stop us practicing in that paternalistic way is to take it away from what we feel comfortable with and have knowledge with, and back to what the patient has knowledge with. And again, that's sort of, if somebody wants to go to a hospice, even then it comes back to the values and fears. Why are they saying that? Will the hospice provide what they think it does? Because that's something I've had recently where they wouldn't necessarily, there are other ways of fulfilling what they want, shall we say. Is it because they know that it's beautiful surroundings, or is it because they know that this particular symptom will get sorted, or is it because there's free parking for their relatives so it's easier to get to? In which case, might the beautiful care home with great community nurses that's just round the corner from their daughter provide just as good 24-hour care?
Or a community hospital.
Or a community hospital.
Yeah. They will take palliative patients.
I wanted to take it back again to what you said, actually, Caroline, at the beginning about ward-based ceiling of care. You don't know what goes on in the hospitals. What I would say is that most hospital staff don't know what goes on in the community.
Yep.
So whenever we're writing clinical recommendations, we really need to help the next person that's reading that. And while I acknowledge that most patients spend most of their time in the community, so our priority should be helping the community, hospitals tend to get involved when there's a crisis. So anything we can do to help those emergency personnel to know what else is out there. And I know I'm very aware that, Caroline, you actually work down very south. Where? Dorset, sorry. Devon, Dorset. I knew it was beginning with D. But the point is that if I write on a respect plan to consider using frailty synapsis, you might have... Yeah, the face says it all. She doesn't know what that means.
I've obviously heard of it, but it's not something that we use.
But at least if I make a suggestion, because you might not know what we have in this area, and at least if this word that just makes no sense at all is written there, you can then probably phone a friend. That might be your local specialist paramedic or someone. So, but even better than not using fancy words, if we can give people ideas, and that also works for the inpatient team. I hear so many stories from people like you, Fiona, where you know your patients so well as the frailty team, and you come in on Monday morning and see they've been admitted, and I know you're desperately trying to get hold of us to say, send them back, we can deal with this, we don't want them in, we've got a plan sorted. So, but it's quite difficult to get hold of the right person in hospital. So writing in those clinical recommendations, either consider frailty synapsis for those that might not know it exists, or complex care at home, or rapid response or whatever. But also, please contact the frailty team on this number, 8 till 5 or whatever your hours are, Monday to Friday. At least then it gives this big elbow to people saying you might be able to get that more complicated information, or we might be able to help you problem solve. And as soon as we can... We need to break down those silos and talk more, and the more phoning a friend we can do. So the phoning a friend works both ways, because honestly, most hospital staff do not have, they just don't realise the extent of stuff that goes on in the community. And I don't pretend that I know all of it. Every time I speak to somebody from the community, I find out about something else amazing that happens in the community, and I think I'm quite informed. So, but let's help everybody both ways.
Yeah, so I think the phone a friend thing is really helpful. And let me take it a different aspect to ambulance service. So obviously we do a lot of telephone triage, and it's not just about the ambulance crew arriving on scene, but what we want to try is actually stop sending the ambulance in the first place. And if I've got, obviously there's a lot of work going on with digital respects at the moment, which is fantastic, and that's going to help a great deal. However, at the moment, if I haven't got a respect form, I might be inclined to have to send an ambulance, because I can't quite get enough information from my telephone triage to decide on what to do with that patient. But ultimately, we really don't want to be sending in the first place, because particularly with all the complexities of it, that crew could be on scene for 2 or 3 hours trying to deal with this patient.
Absolutely.
And that's what we're trying to prevent, is right from the beginning.
And even if we haven't got an electronic form, a patient or a relative or a carer
to be able to read it. Yeah, so care homes are pretty helpful, obviously, when they do that. But again, if we've got no vision of it, or it's not harder. Written very well, then it is extremely difficult.
I did have one the other day where I had a paramedic on the phone to me, and he rang me for advice about, and he'll be laughing if he's listening to this, he rang me about what to do with a particularly frail patient. And I said, has he got a respect plan? And he said, yes. I said, would I class it as a good one? He said, yes, I think it is quite good, but the writing's absolutely awful. I said, all right, can you read what's written? And he started reading it out, and he could read the content. And I said, sounds like it might be me. Could you look at the name? He said, no, I can't read the name. It's dreadful, but I'm sure it's not you. He carried on reading. I thought, this sounds so familiar. I said, what's the GMC number? And he read it out and played me down. It is fine. So he's actually come in and apologised, because he just kept saying the writing was so awful. But I'd done my best writing, and it probably didn't look pretty, but it was legible, is my excuse. And the problem was he knew me by a different name to the one that I'd written it down as. So it was me. Sorry, Sonia, I cut you off with my embarrassing writing story.
I was just thinking that what Caroline's saying takes us back to this whole polygamy idea, because we have to be practical, and people take the path of least resistance, if I'm honest. So if we want this to work well, we have to make it easy for people to do the right thing, make the right decisions, get the right, I'm going to get the phrase wrong, but, best care, right place, right time, right person, first time. So putting all those details of, this is the actual number you call, because I have to say, like you, I have a foot in the hospital and a foot in the community, and things just keep changing. You cannot keep tabs, and you write numbers down, they change. So if it's just where you need to find it, when you need to find it, that's all good and well. And then the other side of it, on the polygamy side, is I get that at 3 o'clock in the morning, the SHO on call might just write ward ceiling of care, because that's what they need in hospital. Our teeth grit as we hear it and see it. But then in this whole polygamous relationship, that person, assuming they survive, will be moved onto a ward or something. And so I often say the respect plan is like a health passport. It is precious. It describes you. It's got your important details. When you travel somewhere, you rock up and you show the officials this form. It gets stamped, modified, whatever. So when they travel within our system, whether it's in the community or in hospital, they come to me. I should be looking at it. If I happen to be the consultant seeing them just before their discharge, that's my point to go, right, this person is potentially going home or care home or wherever they're going. How is this, what's written here, going to help the next person? If it's Caroline who's going to see them, or if it's the community matron who's going to see them, will it help make a decision at a point in time when there is nobody accessible, so that the person can get the best care? And I think that's where the polygamy comes in, and just making wise decisions.
I'm just going to put my mother voice on for a minute and speak directly to any resident doctors or clinicians clerking patients and say you are never, ever going to put ward-based ceiling of care on a respect plan ever again. And if you haven't got time to write more detail, you're going to put not for ITU, or I will be very angry with you.
And you won't like it if she gets angry. And can I come in on the polygamy side, but from a different perspective? So I was with a multidisciplinary group of mostly hospital-based healthcare staff earlier this week, and I waved the Respect Patient Carer leaflet and I said, are you all involved with this? And the only 3 people who responded at all said, oh, well, the doctors do that. So as a nurse, can I say, nurses, physios, occupational therapists, and everybody else who works with people in our care, you all have responsibility. You will get information which is crucial. Please, help the resident doctors.
Yes.
To complete the whole form.
Yes.
And if you need
and make
more
a proper plan,
training, if you feel this, and she won't like me saying this, but our lovely Vicky, who's one of our project managers at the ICB and is sitting very quietly behind me. Do you want to say hello? No, she won't want to say hello. She's waving. She is a physio by background and will say very openly that she has since reflected on her practice as a physio and how much more she could have done in the respect process, because the important bits on the respect process are the bits that you find out anyway in all these roles we're talking about. The clinical recommendations, as far as I'm concerned, is the least important box, as we've already said. But please, this is, yes. Oh, thank you for saying that, Jane. It's not a doctor's job. It's not somebody else's job.
Mm-hmm. No.
And you can keep adding bits.
Yes.
And a note when you're reading them, remember that some boxes might not be completed, but don't throw the baby out with the bathwater. Use what you have got to help you help your patient have personalised care. I think on that note, we've probably talked long enough, unless anybody has anything particularly want to say. Can I thank you all for coming today? So we've had Caroline from SWAST, Fiona from the Community Frailty team, Sonia, my colleague from Frailty team and the community, and Jean, who works with Specialist Palliative Care. And thank you all very much for listening and for talking. Thank you.
Thank you.
Thank you.